Thank you very much for the invitation to speak about this important topic, which is the lung cancer screening with low-dose CT in high-risk population. I'm here to present the results of our surgical cohort after 20 years of experience in Pamplona. Lung cancer is the leading cause of death in the world, surpassing colon, breast, pancreas, and prostate together. According to the statistic of the American Cancer Society 2015, the overall survival at 5 years does not reach 20%. So how can there be such significant difference with the rest? These charts describe the answer. Lung cancer, due to its asymptomatic nature, is only diagnosed in 16 of cases before it spread. So coming back to those charts, how can we decrease the number of cases and the number of deaths due to lung cancer? First of all, prevention. This should focus on raising awareness of the problem in the population and encourage smoking cessation. And how to improve survival when we know that it's directly related to the staging at the time of the clinical diagnosis. There is no doubt that early diagnosis together with early radical surgical treatment is the key, which will only be achieved in a greater proportion with the screening of the population as in the rest of the diseases mentioned before. LDCT is a simple technique that provides the same sensitivity and specificity in the detection and characterization of pulmonary nodules. In the 90s, the ILCAP group, led by Claudia Henschke, began the screening studies in high-risk patients. By 2006, together with our institution as the first and only screening program in Spain, ILCAP grew, unifying 48 centers in 9 countries with almost 32,000 patients. The results were published in the New England, where 484 lung cancer were detected, where 85% corresponded to stage 1, reaching a 10-year survival rate of 88%. And actually, a subgroup analysis of the surgical cohort reached even 92% survival at 10 years, something never seen before. ILCAP is a live and open protocol in continuous evolution and updated with the data obtained from the analysis of multi-institutional work. In 2002, the National Cancer Institute, together with the American College of Radiology, began the NLST, a controlled, prospective, and randomized study with a cohort of 53,000 patients comparing chest X-ray, screening, and low-dose CT. In 2011, they present their result showing a decrease in mortality by 20%. Actually, this study was stopped for ethical reasons after a preliminary analysis showed the significant statistical difference between the two groups. Since then, in 2012, the American Cancer Society, AATS, and NCCN guidelines, among others, together with the US Preventive Service Task Force, recommend the screening for the population at risk. Since then, screening for lung cancer in the United States has expanded rapidly, while its implementation is still under discussion in Europe. So what happened in Europe? Several randomized studies were carried out but lacked sufficient statistical power. That is how the Nelson became the most important study in Europe with regards to the efficiency of lung cancer screening in our population. The Nelson trial, with almost 16,000 individuals randomized into controls with LDCT versus non-screen, finally, the results were presented in Toronto in 2018, showing that screening in high-risk population can significantly reduce lung cancer death by 24% at 10 years and by 33% in men and women, respectively. Following the successful trial in the US and Europe, the ISLC officially declared the necessity of expanding lung cancer screening worldwide. Despite such excellent evidence and support, there are still many controversies surrounding the screening, which have been discarded thanks to the solid scientific evidence. One of the most debated points in the screening programs are false positives. A compromise must be assumed between achieving a high detection rate and its consequent reduction in mortality, with the lowest possible false positive rate, maintaining a balance in decision-making for benefit and outweighed harms. The finding of small, suspicious, and indeterminate null becomes a diagnostic challenge, in which histological confirmation by the CT-guided biopsy or endoscopic techniques might be technically difficult or not even feasible at all. So the proof that will finally confirm the diagnosis will be the biopsy obtained in theater. Thanks to the advance in surgical treatment, the mortality recorded in diagnostic wedge resection and frozen section is relatively low, remaining below 1%. But it's the physical, psychological, and emotional impact that may affect the quality of life in those patients. So we are now able to analyze and describe the result from our entire surgical cohort from the longest screening program in Europe. The objectives were, first of all, describe the characteristics and results obtained in patients undergoing surgery. Second, to analyze a subgroup of patients in our screening program who underwent surgery and whose final diagnosis was not cancer, and determine the degree of compliance with the ILCAP algorithm. And second, compare through 3 validated surveys the quality of care received, information supply, quality of life, and satisfaction. They were matched with a control group 1 to 2 to improve the power of the study, and 3 questionnaires were completed after surgery. Inclusion criteria for screening: age over 40 years, a smoking history above 10 packs a year, asymptomatic patient with no history of cancer in the previous 5 years. Results. From September 2000 to December 2019, 3,825 subjects participated. 97 lung cancers were diagnosed, representing 2.5%. In the screening progress, 87 diagnostic therapeutic surgeries were performed. Based on this, taking into account the surgical cohort, only 20% had a preoperative diagnosis, of which 8 operated patients obtained a benign pathological result, thus resulting in false positive from the screening process. In all cases, a wedge resection with a frozen section was carried out. No one of them had complications. In order to understand our surgical lung cancer cohort, 67 patients remain for statistical analysis. With regards to the demographic characteristic, it should be noted that 85% were men with an average age of 67 years old and 53 packs a year. 83.6% of patients have COPD, emphysema, or both. 24.4% were treated with minimal invasive approaches, bats and rats, and this has been changing radically in the last 2 years of the screening program in our institution, with 92% of patients treated with minimal invasive techniques. Regarding the type of lung resection, 83.6% were lobectomies, 4.5% had an anatomical segmentectomy, and 10% of wedge resection in patients with limited lung function. 55% had a mediastinal lymph node resection. The pathological staging, according to the diagnostic regimen, 60% were diagnosed in the baseline evaluation, of which 88% correspond to stage 1, and 40% of diagnosed were in annual evaluations, where 89% were stage 1. Adenocarcinoma, with 58%, was the most frequent histological type, followed by squamous cell carcinoma, and the estimated survival rate for entire cohort of operated lung cancer patients was 88% at 5 years and 80% at 10 years. For stage 1, survival rate at 5 and 10 years were 93 and 83% respectively. Regarding the false positive subgroup, we discovered that 7 patients out of 8, 87.5%, did not comply with the protocol for the 4 reasons mentioned above. Regarding the quality of life and satisfaction of the false positive, In the absolute absence of significant difference between the groups, the subject showed a high degree of satisfaction with the quality of care in all the items in the first questionnaire, an excellent quality of life in its physical and mental dimension in the SF-12, and a high degree of satisfaction regarding the perception of their health in the SATIS score. And even more, in the last item of the SATIS score, 100% of participants in both groups state that they will undergo surgery again under the hypothetical case of pain under the same circumstances again. To conclude, lung cancer screening using LDCT is feasible and effective and a low diagnosis in early stages. Long-term survival rates in patients with lung cancer diagnosed in the context of a screening program exceed 80%. The proportion of surgical intervention in our screening program that have been consistent with benign disease is 9.2%, which is below the international results, and we're still working hard to improve it. The rigorous follow-up of the protocols could result in a low rate of false positive in the screening process, and the provision of adequate and detailed information on the benefit and risk of lung cancer screening, together with a high-quality multidisciplinary care, may result in a high degree of satisfaction, reducing the risk of lung cancer psychological impact, even in patients operated for benign lesions. The false positive subject, in the absence of complication, show a high degree of satisfaction and an excellent quality of life in their physical and mental dimension. All in all, multidisciplinary teamwork is crucial. Lung cancer screening saves life, and hopefully the implementation in Europe and worldwide will be completed in the near future. Both those communities in which not, as surgeons, we need to strive to achieve it and fight against the system that oppose. It's only through early detection programs that we will reach excellent results and save the life of our patient using minimal invasive procedure and lung sparing techniques, which guarantee reducing risk and surgical impacts for our patient. Thank you very much.